Mind the Gap project as part of our NHS Commitments to Carers programme. My name is Neil Churchill. I'm the Director for Experience, Participation and Equalities, NHS England. I'm also the chair of my local carers charity and a carer myself, so I have a very strong interest in this piece of work. And actually, I remember the last time I attended one of these events, it was definitely a highlight of that working period. So I'm really looking forward to today's discussion. So there are quite a lot of us on the call today. Please do use the chat box for questions. We will endeavour to address questions as we go, but we may not answer all of them today. So we will be sharing a question and answer after the event for the questions which have been raised and the answers which can be given or the comments which have been shared. If you want to tweet about today's event, please do, and please use one of the hashtags that we have used for the programme, which is either hashtag NHS Think Carer or hashtag Mind the Gap. I know that there's a lot of people who also have an interest in this work, who aren't able to be here today, who will be very interested in following some of the discussions. Several of whom I think are up at the NHS Confed this week too. So it'd be interesting to link some of our conversations there. So I think just a little bit of context for me before we start. Recognition that in the most recent plans that we've been pulling together at a national level and at a system level, there is a very strong focus on inequality, which is really good to see. That's one of the areas that I think has really been strengthened in the long-term plan, in the NHS England business plan, which is coming, and in system plans, which are finalising at the moment. As we know, inequality has a number of dimensions affecting carers. There is the fact that our public health colleagues have recognised that caring is itself a social determinant of health, and we know from a range of sources that carers do face inequality and poorer experience and outcomes as a result of their caring role. We also know that inequality is often exacerbated for particular groups, many of the groups that you've been working with who experience other barriers and other disadvantages. And of course, we know that COVID has had a significant impact on unpaid carers who have had to provide more care often with less support over the last period of time, and that it's had a disproportionate effect on many of the communities that we know are already suffering from health inequalities. So I think that this work has become increasingly important and really resonates with a number of priorities that we set at a national and at a system level. So I'm really looking forward to hearing more and looking at following the progress and understanding the recommendations. Certainly from a personal perspective, and that my local system, which is the Sussex system, has identified unpaid carers as one of their priorities in the Core 20+5 programme, which is the programme to address health inequalities. And I'm very interested in seeing the learning that's been achieved in Sussex, but also the learning that's been achieved elsewhere that we might be able to bring to bear in Sussex. So I think this is a very timely event. So what we're going to be doing is sharing the learning from the 2021-22 projects, which are both in relation to embedding work and scoping work, and we will be inviting sites to bid to carry out more embedding work for 22-23. So I think that's enough for me in introduction. It's fantastic to see you all here, and I'm going to hand over to Jen to introduce the purpose of the work. I think we know what the purpose is, but you're going to go into a bit more detail than that, aren't you, Jen?
Well, I don't know. I think you may have stolen my thunder there. Morning, everybody. My name is Jen Kenwood. I'm the Experience of Care Lead for Community Primary and Integrated Care with NHS England Improvement, and I have the absolute privilege of leading the Commitment to Carers team with the work that we do. Steve, could you pop the next slide on? So I'll also make my habitual apology now that I do have a dog as my co-worker in the house. At the moment, he's downstairs having just worn himself out barking at the postman, but he may choose to do that in this room at any point. So please forgive me if he interrupts us. I will mute quickly. So really just thinking about the purpose of this work, and I think Neil's probably captured it quite well with what he said already, in that we know that there are people that just, for many reasons, don't get the support, don't get the recognition, don't feel the same sort of value in the role that they have as a carer, and may struggle more with that recognition and identification as a result of being in a community that's frequently excluded. And there are all sorts of reasons for that. I guess lots of assumptions are made, hopefully less, as we've developed ways of working across health and care systems. So there's less assumption and more co-production in what's done. But I think that assumption can sometimes just weigh people down. And actually, what this programme is about is really getting to know people within those communities, actually understanding what matters most to them and what's going to be helpful, putting down the self-doubt we may feel about accepting different views to our own, and actually trying to look at how we can get to what those people want in a more straightforward way. And I think what's been really evident across the years that we've been working on the carers programme is that much of what we talk about isn't rocket science. It's about listening, it's about being kind, it's about being compassionate, and it's actually responding to what people are asking us rather than what we think they might want. So a really important way to think about how we take this work forward. Next slide, please, Steve. One of my favourite pictures that helped me understand equality and equity. So really just thinking about who the communities are that we're working with. We all know about the protected characteristic groups. And I think it's really important to think about the intersectionality of those as well, because I think that's something we're certainly seeing more of as we've seen more evidence from the GP patient survey, as we've got more evidence in terms of the evaluation that you'll hear about this afternoon from the team at Liverpool John Moore, that actually it isn't just about being identified as one thing. And actually within those groups that are identified within those protected characteristics, you don't have a homogenous type. It's about actually understanding that there is diversity within diversity, if you like. And that also that some of those groups don't fully capture people and communities that may also experience exclusion as a result of the things that they're experiencing. And the examples that have been given at the bottom, so people who are experiencing alcohol and substance abuse, people from armed forces, families and communities, and migrants and asylum seekers who may not think that they're automatically entitled to services, can very easily fall through the gaps. And we know that there is still huge stigma related to carers across the board, and particularly with young carers. We've seen the stigma of that identification, that using the C word, as being a real barrier to getting help and assessment. So today is really absolutely about a celebration of those people who have found ways around that, who have worked really proactively with communities and let those communities take the lead in thinking what can be done differently and better. And so if we go on to the next slide. So we're going to hand over and hear about young carer transitioning from young to adult carer project, and really give us a focus for how this work's being taken forward. And I look forward to speaking to you again towards the end of this, just to share some reflections and think about how we move forward as well. So thank you.
Okay, so Noah, do we have Noah with us?
Hello, yes.
You're there. Hello.
Yes,
sorry.
hello, sorry.
I was thinking that Jen had introduced you, but it's fantastic you joined us, and you're going to tell us a little bit about your experience with the project.
Yes, so I'm Noah. I'm with the Junction up in Redcar and Cleveland in the northeast of England. And our project from Mind Gap has been a transition from young carer to adult carer, so through the different transition steps, whether that be from primary to secondary school to college, and college and beyond, whether that be into university or into the workforce. So part of that for us was looking at different experiences that people have had from transitioning, obviously from a young carer to an adult carer, and thinking about ways we can make that easier, make that less stressful. So we had a look at a consultation to see what young adult carers want priorities to be for a transitions project. What was ranked first was working with education, health and social care to identify and flag young adult carers. That was ranked first. And one of the main things that was brought up was developing a young carers passport, which would be developed from late on in their primary school stages up through to help them transition to secondary school, and then from secondary school to college. So we took that and we started developing that into a fully fleshed out project, looking at different ways we can present it, what needs to be included. And then we got some feedback from the initial ideas stage. What we wanted it to be a journey rather than just telling the story. From my personal experience, transitioning from primary to secondary and secondary to college, it's been difficult having to tell the story again and again and again to different people, whereas I think it should more fall onto the education provider to.
Breaking up. Hello?
Everything all right there?
Hello, Noah. Yes, I think.
Yes.
Yes, I can hear you fine.
Okay.
So do continue.
Sorry. So reflecting the changing situation throughout the life, obviously different things can change with caring roles, different responsibilities, things like that. So it's about making it a living document that can be changed as and when necessary. And then having a look at the way we can brand it, the way we can present it, that it is both informative to education providers, but also easy to read, clear and clearly set out. So eventually we came up with the branding. We came up with a finalised idea, and that was taken to the South Tees Carers Forum on the 3rd of November. And feedback was given by professionals from the health and education, child and adult services. And that was then approved. So we got the final passport and the design for it, which included questions about what a young adult carer is and the facts about that, future plans for the person that the passport is about, their interests and strengths, and then support that they will need, and then that will be given to their school or to whoever provides their education to let them know what is needed. So that passport is filled out in conjunction with a transitions worker that the junction has, and filled out by obviously the person that this is for. And I think that is about all I have, if there's any questions.
Brilliant. Thank you, Noah, very much for sharing that. Could I just ask you what tips you might give to others looking to work with young carers? Bearing in mind you've got real diversity amongst young carers, as you do amongst adult carers, but any tips for working successfully with young carers?
I think and it may sound quite cliche, but involving them in as much as you possibly can. So whether that be kind of taking their ideas on board, or having a small group of people, small young carers that access services, to come together and help make those decisions, or like with this project and this meeting, inviting them onto things like this, so that they not only get that experience, but they also have that first-hand input into projects and things that are going on. And I think that's probably the biggest piece of advice I would give.
Excellent, thank you, Noah. And certainly from my perspective, in terms of wearing my charity hat, Care for the Carers in East Sussex, we brought a young adult carer onto the board as a trustee, and that's made a really big impact in terms of the conversations and how they've been informed, and our plans have been informed. But no, could I just ask you one final question, please? What difference did it make to you and others who were involved in this project, the actual experience of doing the work?
I think it obviously it gave us the experience, and it gave us first-hand knowledge of how we can develop things like this, working in a team, and being able to actually come up with an idea and then present the idea to a group of people, whether that be the board of trustees for the junction, or the other meetings we've been on, and then actually making that project work, making the passport in the end, and actually seeing the project come to a close and having something tangible at the end.
Fantastic, and it's a huge amount of life experience, isn't there? And that I think it needs to be recognised in all different kinds of ways. It just made me think, Verity, at some point it might be quite interesting to invite a couple of the young carers who were amongst the first NHS cadets to come and talk to us a little bit about their experience of that programme, because that was designed to look at what they could do with that life experience, and how it integrated with routes into the NHS. Thank you very much, Noah, for sharing that. It's really really helpful to hear from you. What we're going to do now is to find out a little bit more about some of the work that has been going on, and people are going to be automatically assigned to a room which is going to give us a flavour of the projects, and each site is going to have about 10 to 15 minutes to present. Now, case studies for all of the projects are on the Futures platform, so if you are a member of the Futures platform, do have a look there. If you're not a member, then let us know. We'd be very happy to welcome you there. So if I could just remind you, please, to stay in your rooms during the break, because we will have a 10-minute break while we are talking listening to the case studies, and then we will all automatically be brought back at the end to hear about the evaluation from colleagues at Liverpool John Moore. So I think we're ready now to be automatically assigned to our rooms. Thank you.
Steve's working that magic for us, I think, Neil.
That's good. I know we have to be patient, but and thank you, Steve, for. There we go. We've got the countdown. So see you all again soon.
I think this is it, Cambo.
Is this our breakout room?
So yeah.
It's funny. In the olden days, it used to feel like Star Trek. You used to kind of you know, like suddenly appear in the breakout room. And now I'm really nervous. We're in the main room and I've just said Star Trek. Anyway.
Well, you've got me at Star Trek. I mean, you know, this is the best group ever already.
And on the holodeck today, so I'm just trying to see, unfortunately, one of our presenters this afternoon isn't able to make it. The team from Connecting Carers in Lancashire and South Cumbria. So it means that we only have 2 presentations to get through before 11:55. What it does mean is that we've got 10 extra minutes, 10-15 extra minutes. So I'd like to use that time as best we can, whilst also acknowledging the fact that we really need to be careful with time. I've done these before, and we can rattle through. So could I suggest that, given we don't have time to do an introductions, but one of the soft benefits of these sort of workshops is always that it's a great chance for you to get to know each other as well. So please use the chat box, use the @ thing, share email addresses, and let's keep connecting. So just a quick run through of what we're going to be doing today. We're going to be recording the session. Sorry, I should have said hello. My name is Campbell. I am a leadership support manager working on the commitment to carers agenda across the North East and Yorkshire region. And my role today is to chair this session and to drive it through. So Steve, do you want to put your hand up? Is very kindly providing technical support. So Steve, can I just check that we are recording? We are, I can see that, that's cool. And as I say, the reason that we've gone with this approach of assigning people into the group is just given the real interest in the work that we've got. There's over 300 people in the main group, so that's why we've had to do it into these kind of breakout sessions. Just sort of housekeeping, be really grateful at 11:55 when we go into the break, if you could just stay in this room, but go on mute, turn off your camera, and then there'll be a break, and then we would ask you to come back it's just a 10-minute break, so we ask you to come back about 12:05. So yeah, so I think that's us. Steve, have I missed anything from the tech support information?
No, that's it basically. And just say people, if they've got any questions, they can put them in the chat box. And if we haven't got any time to get back to you with any answers, if the presenters haven't got any time, we can always collect them and send the answers back after the session.
Wonderful. So let's get started. So the 2 projects that we're going to talk about today are ones that I have had the pleasure, I would argue, and it very much has been a pleasure over the last year of working closely with. This one in particular, as an ex-psychiatric work, as an ex-psychiatric nurse, working in the addictions field, I've had some really particular interest in this project from the York Carer Centre. And can I ask who's going to be presenting? Is it Michelle, are you doing it? Is it Carol, Samantha?
Hi, Campbell, it's Samantha here. It's myself and Carol that's presenting today.
Wonderful. And could I hand across to you, please?
Thank you. I'm assuming Carol's somewhere here.
Here, yes, I don't know if you can see. Can you hear me?
Yeah.
Yeah.
Yes, thank you.
You've got 10 minutes and I'll give you a little nudge when we get to the end, if that's okay.
I'll rattle through then. Yes, Carol Zagrovic, co-presenting with Sam. Really grateful for the financial support to evidence this area of need for carers. Our project was Caring to Recovery, focusing on carers affected by someone's substance or alcohol misuse. The project was York-wide, not the broader area of the Health and Care Partnership, and carers were engaged throughout the project. They were very enthusiastic to share their experience, but this was also an emotional and often painful journey for them. Online focus groups worked really well, facilitated by mainly by Sam and Michelle. 6 months isn't long for a project of this nature to build the relationships that enable to people to share such an emotional journey. But we're very fortunate that our member of staff at the charity, Sam, has a raft of skills and experience in drug and alcohol services in a previous role. And we had a number of carers already registered with our project, with our charity that knows Sam reasonably well. However, even with assuring confidentiality and anonymity, it proved very challenging. People were very afraid that the person that they supported may be recognised through their engagement with this project. However, carers wanted their voice to be heard, and they agreed to make 3 short films that could be seen by a wider audience. That was very important to them. And we're going to show one of these films now that clearly demonstrates the challenges that carers face. And then Sam will run through slide 3. We've only got 4 slides in total. So if you would put the next slide on, that should give us a link to the film, which is Claire's story. Thank you.
Just to check, can you hear it? Could you hear the sound? No? Okay.
No.
Not yet.
No.
Steve.
Just bear with me 2 seconds.
Thank you. Wouldn't be a proper Teams call without a little.
And I picked up and I thought, oh, that's a woman, that's a bit strange. So it was one of the nurses, and the first thing she said to me was, don't worry, but your husband's in A&E unconscious. My stomach dropped, I froze, I was so surprised. And I went down to the hospital to see if I could help and to find out what happened. As far as I knew, he'd been at work, and I thought he was still there, so I was really shocked. He'd been found unconscious by a member of the public and brought in by ambulance. When I got to the hospital, I wanted to check that he was still there. So after wandering around the hospital lost for what seems like hours, I kept calling him. I kept thinking maybe he'll answer his phone and tell me what's going on, but no answer. I found out he's still in the A&E department, so I went over there and I spoke to the receptionist. She said I couldn't see him because of COVID measures, and she couldn't tell me what had happened. They didn't know what had happened, and he hadn't been seen by a doctor. They kept telling me that they'd call me when they had more information, as did the nurse, but nobody ever called me. I never spoke to a medical professional that day, which could have been so much better. The receptionist told me to wait in my car, but I didn't know where the car was. My husband had the car before he was brought into hospital. So I just went outside and sobbed and called my dad. It would have been much better that day if I'd been able to speak to a doctor or a medical professional. And nobody spoke to John about his addiction that day or spoke to me when he was released to go home. There was no indication of anything that I should look for. Because he'd hit his head, I was still quite concerned, but they just said, okay, take him home. There was no follow-up, there was no letter to the GP, there was no connection with addiction services at all. It was an awful experience, but it could have been made much better if there was something like a 24-hour helpline in A&E where people might turn up with addictions, or some sort of liaison with an addiction specialist who could then follow up when they were in a better headspace or if they were sober. That would make a massive improvement to the addicts and to the families of the addicts, and I think could even save the taxpayer money by treating the problem, not just sort of dealing with it when it comes up time and time again and letting the cycle start again. I think the stigma for addiction is really strong, and it affects loved ones as much as it does addicts themselves. I think people don't want to admit that there is a problem, either themselves or for someone else. I think that stigma puts people off accessing support and help. if it was more visible how many people are affected by someone else's addiction, then I think that would reduce the stigma and make people realise that it's not as uncommon as you think. You're not alone. You won't be judged. There's lots of other people in similar situations who can help you. I think it would be useful if addiction services and services for people who care for an addict were more linked with mental health services and health services themselves. I think it's a barrier in that everything's treated so separately rather than in a holistic way. And I think there would be less stigma if addiction was treated as a medical condition and treated in a healthcare setting rather than an independent setting. It's really hard using the word carer. It's taken me some time to get used to that. And it's perhaps not the first place that people would look for help. At first, you mainly want help for the addict. You think that that's what needs to change. You don't think about helping yourself. So it would be good to have sort of signposting when the addict first gets referred to help for the loved one as well. I'd like it if more people accessed the service, if it was more visible or sort of frequently signposted to people that might need it. I know there's lots of people affected by other people's addictions, so I'd like as many people to get help as possible.
That was Claire's story. I mean, one of the carers, there were a few carers that were willing to share their story from different backgrounds. But one carer that accessed the carer support and the support groups that we ran found that stitching her feelings, if we can move on to slide 3, Steve. She found that stitching her feelings onto fabric helped her cope. It was part of her work, and she was very good at it and wanted to share this with other people. So she sent out about 60 sewing fabric packs to people that expressed an interest as part of a campaign that she set up. And her work contributed to an exhibition in York in November last year called Stitch Away the Stigma. And that also raised funding for the substance misuse group at York Carer Centre. Her work was recently featured a couple of weeks ago on a Channel 4 documentary with the singer Will Young, who spoke about his brother's struggle with addiction and stigma that led to his death in 2020. So all the while that he was coming to fame, his brother was really struggling with mental health and addiction. And one of the comments that he made was, "I hope it shines a light on the difficulties that so many people face today in the UK with addiction and getting the necessary help." And that particular carer was part of that documentary and was able to show and share. And as a result of that documentary, that raised a great deal of awareness, and lots of people have been in touch with her since. So she's sending out hundreds and hundreds of packs to people that are wanting to stitch away the stigma and put their comments onto a piece of cloth that she's going to extend and hopefully hang again in another exhibition. Throughout the project, carers expressed their feelings of shame, guilt, embarrassment, denial, and stigma, as Claire said, and as the other carers have said, is a real barrier to people seeking help that they're entitled to. And as a result of the campaign that the particular carer that developed Stitch Away the Stigma put together, more carers affected by addiction have come forward in this area that didn't know that they were entitled to some support and that the Carer Centre offered any support. So they're not only getting involved in stitching, they're also now getting involved in taking steps to access some support with the Carer Centre. Can we move to slide 4, please, Steve? I think we're over to you, Carol.
So we have a number of recommendations that came out of that work. Thank you, Sam. We believe engaging people in that creative way in making the films was very effective for group members to express and share their experience. And the material will not only raise awareness, it'll empower underrepresented people to have their voice heard and help overcome the stigma. Then again, it's very much about promoting carers' rights, because people struggled with the term carer and still do. However, if it's not identified as such, then carers are unaware of their statutory rights, such as those provided through the Care Act and the support that statutory organisations should be providing them with. Carers centres play an important role in identifying carers and helping them claim their rights. I think with professionals training as well, it's important that professionals understand and can identify carers and the challenges they face. Many of the carers that participated in the project reported some GPs were unaware of what support was available for carers or where to refer them to. Similarly, with carer training, carers discussed their lack of understanding about addiction treatment and recovery. They felt they had a role to play in care planning, but they felt ignored and undervalued by the professionals working with the person being cared for. And carers felt that professionals ignored then that potential that they have to help and support with recovery. Sam, do you want to go on from there?
I was thinking that going forward with the professional training, that we would look to raise further awareness with professionals in healthcare settings, such as GPs and the health and social care and third sector workers, and also by delivering care awareness training so that professionals know how to identify and support carers and where to refer them for help. I think that's really important, getting known and being able to break down the barriers that we've talked about, the stigma, and also the identifying as a carer. And in regards to carer training, I think it's important that professionals don't hide behind confidentiality, which is a main issue, especially in the field of addiction that we come across, but rather provide carers with access to information and training as early as possible and listen to them as a partner within the care of the people that they're supporting. So we would be really keen to enlist the help of experts such as drug and alcohol treatment specialists and mental health staff who understand addiction and can offer more specific workshops on particular substances, dual diagnosis, recovery. And York Carers staff, myself in particular, would be able to offer specific sessions with carers around identifying and setting boundaries, maintaining those boundaries, helping them explore what's going on for them, what they want to change, helping them recognise and reduce enabling behaviours, and then explore a range of coping strategies from there. Carol?
Yeah, I think just the final two were really what Sam has just really highlighted about collaboration. Carers feel constant pressure to coordinate the range of support for the cared for, whilst at the same time feeling ignored and undervalued. This was particularly an issue around dual diagnosis, and I think Claire's story touched on that. So there's a need to better join up health and social care and third sector support that can recognise care as an integral part of their treatment and recovery. And finally, the peer groups. We found the facilitated peer group support was hugely important and very effective. Members of the group felt that their concerns were validated, whereas previously they felt isolated and lonely, if you like. So members felt comfortable sharing their experience with each other, many for the first time, with people who understood without judging them. So establishing peer groups, particularly that recognise diversity, would help carers around mutual support, and through a facilitator they can then access the range of carer services, including a statutory assessment, which is hugely important, and other through carer centres and third sector organisations. That's about it, I think, Sam, is it?
Sam,
yeah.
Carol, just to say thank you so much for that. Absolutely brilliant to see not just a carer story, but to actually see a video. And I do think that those videos have a real impact and really set out the stall for the tremendous work that you've done. Given the time, what I'm going to do now is hand across to Hazel. Is Nick with us? Is Nick Marlowe on the call?
No, sadly, she's got an operational issue that she literally can't
No.
leave. So, so at about 5 to 11, she mentioned to me, "Could you present?" So I've had a quick run through the presentation, and I'm happy to step in for it. But yeah, so I'm happy to take that.
So I'd like to introduce everybody on the call to Hazel Cuthbertson from South Tyneside, and again, it's been a pleasure to work with Nick and Hazel over the last year on this project. So I'm just going to hand straight across to you, Hazel, because of the time.
Lovely, thanks a lot. And your support's been really appreciated, Campbell. And as we go through the presentation, you'll see that we've had some challenges along the way, and it's been really great that Campbell has recognised those and been supportive of the different approaches that we've needed to take as we've continued with the project. So Steve, can you move on to the next slide, please? Thanks very much. So what do we say we do? So our bid was based on the fact that pre-COVID, I was really struck by a comment that a carer made on one of who attends our strategy group about the responses that they had as a dual carer. So he was a carer of his mum with dementia, and he's a carer of his son with drug addiction. And the difference that he described, being praised and adored for caring for his mum with dementia, "Oh, aren't you amazing?" But then the challenge and the criticism he was getting as being a carer for his son with drug addiction, and that had always stuck with me. During the pandemic, obviously in South Tyneside, we've always had quite high prevalence of substance misuse issues, alcohol and drugs. But during the pandemic, we saw a significant increase in alcohol harm, and we just felt that this was an area that we wanted to, and we saw the opportunity for funding, that we wanted to take the opportunity to do something about it. So this was a collaborative bid between the local authority, and sorry, I've dived straight in. I'm Hazel Cuthbertson. I'm Service Manager for Early Help, and I'm since September last year, I've been based in the Joint Commission Unit, and more recently have the Carers Lead. I'm a registered social worker by background, and have spent my career up to this date in operations. So it's fairly new being in the Joint Commission Unit. But the bid was, as I say, co-developed between ourselves, the local authorities, including public health, First Contact Clinical, and a number of VCSE providers who obviously we engaged with as we were developing the bid, and that in itself was really, really insightful. First Contact Clinical delivered the project, and they've been around since 2003, initially working in the world of alcohol and substance misuse, but they, in probably about the last 10 years or so, are more involved in improving health and well-being of people, where their lifestyle negatively affects their health and happiness, and they work primarily through enabling healthy behaviour change. And they are the largest social prescribing provider in South Tyneside, and they work into all the GP practices with social navigators, social prescribers, and health coaches. So what we want to do with the project is we want to understand what matters to unpaid carers, people who misuse alcohol and drugs. We want to understand why the carers are underrepresented in all of the carers' activity in South Tyneside. We want to understand the barriers and issues they experience, what matters to them, the kind of support they identify to be beneficial. And as well as being shared with the ICS and South Tyneside Council, we're committed to ensuring the learning would shape the delivery of the key priorities in the local carers strategy, which was in development at the time of the submission for the funding. So Steve, can you move on to the next slide, please? You'll have to forgive me as well. I'm kind of reading off a set of notes from the presentation that Nicola sent me because of my lack of familiarity with all the different slides. So I'm just doing that at the same time. So how did we intend to do it? So what we wanted to do was complete a survey with people. We wanted to identify carers through our relationships with local organisations, that we would then have one-to-one interviews or engage in other activities. We wanted to hold a number of focus groups with people who identified as carers. And the other key thing that we want to do, and this was incredibly ambitious, and this is the area of the project where we weren't as successful, was we wanted to recruit volunteers who would then train in peer-based research techniques. So we'd equip volunteers with the knowledge, the skills, the confidence to reach out and talk to other carers, and then the information gathered we used to develop a report, which the volunteers would be supported to do themselves. And we were committed from the outset that all of this work would absolutely inform and be co-produce the carers strategy, and that we wanted to then use that information to support and develop a very clear communications campaign, and then also look to developing some embedding work around toolkits. Next slide, Steve, please. So what challenges did we face? Well, obviously COVID did have an impact, and the usual methods that we would use to assertively engage with this group of people were limited due to COVID restrictions. And whilst when we were writing the bid and we started the work, we had hoped things were improving, but of course then impacted with the Omicron variant. So we had like kind of a double impact. As well as limiting the way we were able to engage with people, the people themselves were also impacted by the continuing pandemic, as their caring responsibilities becoming increased and their capacity to get involved in activity beyond their caring role decreased. We underestimated the stigma. And so one of our goals was to train volunteers, become peer researchers, and they'd go out to the community and speak to people who might not usually have access to. Those people that we did engage with just weren't prepared to take part in this activity. And some of the reasons for this related back to the stigma associated with being a carer of this group. I think it's an ambition we probably want to continue, but that we don't want to lose sight of, but the timing just wasn't right. We were overly ambitious at that stage. We all know, and as we anticipated, the vast majority of people we engaged with didn't identify as a carer. And I thought it was a really interesting point, Carol, that you made before, though, that it's a critical gateway term, though, isn't it? But anyway, when it came to kind of trying to promote what we're doing, we amended our communications. I'll show you some stuff on the next slide. And some people did actually come forward as a result of that, not the carers themselves, but the people with the substance misuse issues. And of course, different priorities. Our communications were effective in reaching relevant people, but when they reached out to us, it wasn't to take part in the research, but to seek support for themselves or their care for individual. So we did connect people into support, but not necessarily into the project itself. So next slide, please, Steve, which shows our kind of like 3 different stages of communication. So our first initial communications are, I suppose, fairly standard, typical, when we're trying to reach out to work with people. And we heard that people weren't identified as carers, the message wasn't reaching them. We heard that the ask of getting involved in training was actually putting people off from getting in touch. So our second communication, our version 2, was about not using the word term carer and reducing the ask as a way of just trying to, not deter people from getting in touch. And then a third strategy that we developed was where we kind of like went through gatekeepers. So we used some of the learning we'd achieved through delivery of the project, and we learned that people caring for people within this group were unlikely to seek support for themselves, as we generally know, but they'd be more likely to be made aware of it through the cared for person. So we approached pharmacists to put a leaflet in the prescription packs for the medication that issued for substance misuse, and that was actually really quite effective. So going through a third party was a really good way of doing this. Next slide, please. So where did we attempt to engage people? So we worked through organisations already working with carers. That's our Young Carers Service, our Kinship Carers Support Group, our mental health concerns, and not just our normal carers groups, but really quite wide-ranging. We worked with the Drug and Alcohol Recovery Service. Within South Tyneside Foundation Trust, we were one of the first sites to have an alcohol care team. Our young person substance misuse programmes, so quite wide-ranging within our VCSE partners. We went through primary and secondary care, including pharmacy, so all 21 GP practices, sexual health service, X-ray department, urgent care, psychiatric liaison teams. The First Contact Clinical are incredibly well connected to all of those organisations, and they use their relationships as leverage to promote the research and what we're trying to do. Other support services like probation, Northumbria Police, DWP, veteran support, which was really critical area, and then other kind of community notice boards and those kind of public campaign messages and sites. Next slide, Steve, please. So what we achieved, well, despite the barriers we faced, we were able to deliver some safe focus groups face-to-face in November last year, which were developed with our adult recovery service. We did actually engage with 8 people, and the insights and their experiences and the accounts that they were able to tell us have been incredibly compelling, and we've shared those quite widely within South Tyneside and other areas. We've connected 4 people to ongoing support, and as a result, so as I say, 4 of the 8 people went into support with local providers of social prescribing or others, which was really great. And of course, we learned a lot. And one of Nick's personal reflections, if she was here, was just being really conscious about what we originally set out to achieve. And she can honestly say at times that, well, we all did, that we felt we weren't delivering on the overall project because we weren't meeting our original aims. But she felt really supported that every barrier we came up against, everything that didn't quite work out to plan, every person who didn't see their engagement through the end of the project was providing such rich learning for us. And actually, that was the overall aim of the project. So whilst we didn't gather the information using the methods we'd hoped for in the way we anticipated, we serendipitously, and I can't say that word, but you'll get what I mean, we learned so much throughout the process about the needs for this group of carers that it's just such rich learning and insights to inform the future delivery of services and the things that we might not have learned about having gone to plan. So next slide, Steve. I'm really conscious, actually, I just looked at the time, there's only about 2 minutes left. So we've learned you can never share information too many times. We've learned meet people where they are. Don't have expectations that people might not be able to live up to. We've learned that learning and education can massively help. Knowledge about the condition the person's facing could support the carer about how best they can support, understand the perspective of the cared for person and how to interact and have conversations. And that carers as this group are unlikely to actively seek support. We need to do far more as a health and social care system to really engage and make ourselves available and offer the right support for these carers. And lived experience is key. One of the things that people talked about is that whilst it's great to have empathetic support workers, they wanted professionals to have lived experience as well, because we heard that empathy isn't enough. What's really needed is a true understanding gained through lived experience. And one of the quotes is, others, normal people, don't understand. Next slide, Steve, please. So local impact to date has been really significant. We've used this research and the evaluation process as a way to bring together a wide group of organisations in South Tyneside to start looking at different things. So Adult Recovery Service are now doing a family carer open day. They've built new questions into their initial assessment document, not just about who's in your support network, but specifically identifying them as a carer, but also asking the person in treatment if they too are a carer. They weren't doing that before. We're looking at other significant touch points in the system and what specific information we might be able to give to the people in treatment to be able to pass to their family members so that they've taken some responsibility about helping their family members and their friends support them effectively as well. Next slide, please. So obviously regionally and nationally, we're sharing this report obviously here today with the North East North Cumbria ICS with our regional ADAS carers network as well. And obviously we've been fortunate that we've been part of the Liverpool John Moores evaluation. We'll hear some of that this afternoon as well. And then the final slide, Steve, please, is really just we know the areas that we want to embed. We might not be at the stage we had thought when we submitted the bid nearly 12 months ago, but we know there's an awful lot more that we can be doing, and that's being shaped and informed as well by carers who've also been involved not only in co-producing the carers strategy, but are now working to co-produce our delivery plan so that carers of drug and alcohol, people with drug and alcohol misuse issues are central to all of our thinking and practice. And that's just not going to go away now. It's just how we do things and how we think. So I'm really sorry I've taken us right up to the wire there, Campbell. That's my lack of familiarity with the presentation as well.
No. I think it's wonderful. And just closing remarks before we go to the break would be, I'd just like to thank both of the teams, because I think a common theme that you've both identified is stigma, is shame, But what you both have done, given that, and also through a pandemic, is that you've done amazing work to actually go out and hear the voice of carers with a lived experience. You haven't made assumptions, and that's been a really difficult process. And I think as a result of that, we've got some amazing lessons that can be learned. And I'm really pleased to say that both of the projects are currently looking at ways of getting that information out, so it doesn't just stay with you, it's going out to the whole system. So thank you very much for that, both. And with that, we're going to stop for a break. So as I said, be grateful if you just don't dial out. Switch off your cameras, switch off your microphones, and please come back at 12:05. Thank you all. See you on the other side.
Oh, hello, Caroline. Oh, I think you're on mute.
Yeah. Are you okay?
Yeah, good, thank you. Have you joined our group?
Caroline, I need to move you.
Okay.
I'm
I'm the wrong room.
You need to go
Bye,
to room
Charlotte.
4. I'll move
Okay.
you.
Oh, bye.
Okay.
you.
Is there anyone else here who has come back into a different group to the one that they left in? It's Verity. I've just spotted
Yeah,
Verity.
so I
What
should
you
be in breakout room 4. There you are, Steve's in charge.
What you doing in here?
And where you put me, Steve? I'm at your
Hold on, I just had to move Caroline as though she turned up in here. Hold on.
the power that
This
you
is
have.
the room to be in, clearly.
I know. Hold on. 2 seconds.
Thank you, Steve.
It's all right.
While Steve's working on that, I might just get started if that's okay, in the interest of time. So hello everyone and welcome back. And I'll just quickly introduce myself. I'm Charlotte Harris and I'm the carers lead for NHS England in the South West region. I'm going to take the reins from Campbell and chair our session over the next half an hour. It's really great to be involved today and so powerful hearing from Carol, Samantha and Hazel this morning. Unlike our previous session, we've got 3 presentations. So Steve and I will be trying to keep us to 10 minutes each, if that's okay, as people will automatically be rejoining the main room at 12:35 and we wouldn't want anyone to be cut off mid-presentation. So that's probably enough from me, actually. And when Steve's ready, I think he'll pop the slides up for our first session. There it is. That's great. So we'll go over to the team in Frimley Health and Care to share their project.
Hi, morning everyone. My name's Katie Humphrey. I'm the carers lead at Berkshire Healthcare. I'm hoping that Dawn West is still in this group. Yes, I can see her there, and that Jonathan is able to join us as well. I'm not sure if he's here, but hopefully. So next slide, please. We thought we'd start with a little recap of just who we are. We're commissioned by NHS England to deliver the Op Courage services, which is the Veterans Mental Health and Wellbeing Service. So that's across Berkshire, Hampshire, the Isle of Wight, Oxfordshire and Buckinghamshire. And what we really wanted to do at the beginning of this is get that feedback from friends, family and carers who support armed forces veterans about their experiences and their attitudes of accessing mental health services, but also not just from people who have access, but also those who haven't accessed or might potentially in the future. Next slide, please. Hopefully there's yeah, if you just want to click through these. So it was we wanted to target carers from a variety of networks, and we worked in partnership with the Ripple Pond, a voluntary organisation, and that was really one of the key highlights of the project, because we were able to access their membership and get a wealth of information from them. Do you want to click the next? There's 2 more. You can just click them up together, Steve. Thank you. So we wanted to look at that quantitative data. So we did a short questionnaire that was sent out to the carers. It took on board sort of demographic information, gender, age, whether they had been in the military themselves, which military service their veteran was from, the length of service and how long they'd been a carer. And we also then asked them whether they'd be willing to participate in some one-to-one interviews or focus groups. And there's one more click, I think, for the qualitative information that should fling up there at the side. So then we held some focus groups and mini focus groups and interviews. Next slide, please. So what did we find out? Well, really the preliminary findings, they were clustered into 4 themes. The first thing, as we've already heard this morning, is that key thing about language and terminology that people don't, the label of carer doesn't recognise. People don't distinguish between their caring role and the role that they have as their relationship with the person that they're supporting, be that whether they're a spouse or a relative, etc. And some of them actually felt quite uncomfortable about the term carer. And also that we've felt that the feedback suggested that because neither the person supporting the veteran nor the veteran would identify as a carer, they were potentially being excluded from accessing information or care that might have been relevant to them, because they just weren't going to look for it in those sorts of places. And there was also feedback about the uniqueness of caring for veterans that inverted commas civvies don't understand, and that some of the best help that people felt they'd had was from people that had had a military experience as part of that as well. So when it came to navigating NHS services, no surprise, again, it's quite complicated. They felt things were in silos, nobody understood what to expect, and they felt it would be really helpful if there was some kind of overview or who to contact. And it was understanding that uncertainty at the outset, that you really don't know what you need to ask or what you should be asking, and they wanted to be far more involved, and for organisations to make it easier to involve them in helping their veteran access support. And as I think somebody's touched upon already, understanding that confidentiality and consent about sharing information with friends, family and carers can be seen as that barrier. Next slide, please. So one of the other things was that it came very much across that they were thinking of their veteran first, not themselves, that caring was part of their busy lives, but actually it's caring and supporting that loved one. It's the unpredictability of the situation that adds to their stresses, and you just don't know what's going to be a good day, a bad day, or what's around the corner. And that can make people feel quite overwhelmed at times and a little bit helpless and quite emotional. The data that we got and the feedback was really honest and quite raw at times, and we also put measures in place that if we felt people, based on the feedback, needed any additional support, that we would go back to them and do that. We recognised that people wanted to look after themselves and the importance of looking after themselves as well. And one of the key things that came across is that if someone went to a session or something, the veteran might then come home and as it was described by one of the carers, that they had to pick up the pieces from that session. So it was very much felt that an increase in education and advice on how to support that veteran, and also potentially to support them after they've been in a sim session or had some treatment, and clarity about boundaries of what's acceptable behaviour as well, because some of the feedback suggested that people felt, or others had said to carers, that you just have to put up with it because they've got PTSD or whatever. So there was quite a lot of data around that as well. Next slide, please. So what did we think was a success? Well, really our team working with our ICS partners, both the voluntary sector, our partners and other NHS colleagues. We had a project group and we had a huge range of diversity on that group. Carers, veterans, psychologists, myself as the carers lead, Dawn as the service manager. So we really had lots of different views and perspectives, and that made the ideas and the collaboration really well, even better, we felt anyway. But the honesty and the openness of the carers and the rich data that we got back, that was a huge success. We worked with an independent research company and they were really flexible, because initially it was difficult to get the carers on board for their availability due to their caring responsibilities. So as much as we'd planned to have 2 focus groups, bigger focus groups at the outset, we had to be a bit more flexible and have some mini focus groups and one-to-one sessions. And we also extended the time frame within which we were going to do that. the comment there about validation and identification of barriers and solutions really was that previously there was a lot of anecdotal information that people felt some of these things were coming through, but we felt that the evidence that we got back from the carers really supported what had potentially been thought before, so we could actually move forward with some of the ideas and suggestions that we wanted to work on. Next slide, please. Challenges, again, like everybody, because of the timing of this, it was lesson learned for the future is when you put the bid in, we kind of didn't wait. We waited until we heard whether we were successful before we made more plans. But actually that meant that we lost a little bit of time at the beginning, which then meant we were pushed a bit more up to Christmas and winter pressures and things when it came to hosting some of the focus groups. And we lost some staff from the project group back to frontline due to COVID. So those were some sort of practical challenges that we had. The availability of the carers, as I've mentioned, due to caring responsibilities, and ditto for the end of the project, it kind of led into Easter. So again, there were some timing issues there, but we've learnt lessons for the future about being realistic about some of those timescales and making plans in advance of what we might do if we are successful in getting funding. And our biggest challenge really, because of the wealth of the data, was that we had to identify what our project outputs would be within a timely manner for this particular part of the funding that we had. So we've got a lot more ideas based on that data, and as someone said earlier, we want to share those findings more widely and potentially nationally as well, because we think that there's a lot more in there than we can actually do within the bounds of this project, and we'll be looking to potentially collaborate on other projects in the future. And Dawn just sort of texted me as well. Part of the veteran community, obviously they're potentially disproportionately represented in some of the other vulnerable communities like the drugs and alcohol. So again, maybe we could work in partnership with some people here on something like that, we'd welcome that opportunity in the future. I'm going to hand over now to GP if he's here, or Dawn if he isn't, for the next two slides about what our outputs have been.
I am here, Katie.
Whee! Perfect.
Sneaking under the bar.
Perfect. So John's our veteran peer support worker. Go for it, John.
Well, I would say I'm one half of it, or else Ross gets very upset that I don't give him enough recognition. But one of the really big things that came out was very much the web page, and exactly how we could get the information out to friends and families, and it all went down to, as it says there, things like the language. But a couple of the points that came out were things like with the websites that we were showing to folks, that the language was a bit cold. They wanted a bit more of a warm, sort of welcoming kind of language in it. The imagery, something simple like, they actually said, can we actually have a picture of a family unit on there, or a family on there, which seems to be a bit of a no-brainer, but it's just something that actually really helped to get it back. And the structure as well. There's some really good points coming out about having a big, easily identifiable, how do I get help now? I think that was one of the biggest things that were going on. I think on the next slide that we've got, please, if you can bring that one up.
Can I just very quickly jump in, Jonathan? I'm so sorry to interrupt you. We're running out of time, so and I'm really sorry.
I'll be really quick. Honestly.
Thank you. That's lovely. Thank you. I'm sorry.
One of the things that we're working on at the moment, and it's on the next slide, is some videos that we're looking at producing, some bite-sized videos, because one of the comments that was made was, I haven't got time to sit through long videos. I haven't got, I need it now. I'm probably doing other things while I'm watching them. So one of the things that is coming out from this is that we are going to be producing some videos based on from memory. Can we move on to the next slide? I think it's going to give me the mental prompt of exactly what the videos were, because I've got a complete blank. There we go. Yeah. the 3 videos, and we've already presented this information to SAFA and also to Ripplepod. So we've sort of given them as a trial run. What we're going to do now is we're going to transpose those into, break them down into 3 areas, but they are going to be co-produced using the clinical psychologist. I'm getting involved, and we've also got somebody involved as well who is from a military family. So all 3 of us will be working on presenting this and working on the information going out. Is that quick enough?
Well, there's one more slide, and we'll just tell you our best bits, I think. Oh, it's about the sustainability. So obviously the way that we went for it was that it was a website. We've got accessibility on there. It's going to be modular. We can add to it. Our target audience could also extend to healthcare professionals as well as veterans and their friends and families. And the idea being that we can add to the workshops either face-to-face or through those videos and written resources too. Thank you.
Thank you so much, and I'm so sorry for having to rush you sharing that absolutely brilliant project. I'm going to hand straight over to Chris in Dorset. We've got 15 minutes to get through the next 2 presentations. So if we could just bear that in mind, but really excited, Chris, to hear about the work that you've been doing in Dorset with partners. Thank you. Over to you.
Thanks, Charlotte, and thanks, Berkshire. That was really brilliant. Steve, can I have the next slide, please? So, oh, look, it's slipped about. So my name is Christopher Beale. I work for a charity called Prama. We support older people and carers here in Dorset, and we have principally worked with the Veterans Hub, which is a community group based down in Weymouth, and as the name suggests, set up by veterans for veterans, and also a national charity, the Defence Medical Welfare Service, which supports veterans and serving armed personnel across the UK, and actually also in theatres of war in combat. Other key partners to the project is, I've listed the ICS partners there, who are really, really important. And interestingly, each one of those roles is actually filled by a veteran themselves. So they may be working for the NHS, but they come with a wealth of experience of the armed forces community. Then one of the really beneficial things about our project, and like Berkshire's as well, is there's a much wider network of particularly of community groups, associations around the armed forces. And that's really, really good in terms of disseminating information and getting feedback back. And I should have put the 4th partners at the top, really, because of course, key to all of this are the carers themselves, their families and friends. And as part of our work, we have spoken to 202 carers and cared for people to get a much better idea of what's happening down here in Dorset. Next slide, please, Steve. So I just wanted to cover some of the key barriers to engagement, and just building on what our colleagues from Berkshire said. One thing we have found out from discussing things with the carers and cared for people down here is a specific difference between carers from the armed forces community and the general population of carers is that they tend to start caring at a much younger age. So people tend to come out of the military around about the age of 40 onwards, and at that point there is a significant amount of caring going on. And of course, that brings a specific challenge in that invariably it means the carer is continuing to work, continuing to have to earn money, as well as deliver their caring role. Another key thing we found out, and not surprise, is that a lot of the carers we were talking to, only 50% were registered with their GP, and only 50% of all respondents were registered as veterans with their GP. So again, in terms of sort of like being able to engage with people through the normal routes, that you know, we didn't necessarily have that opportunity. Like Berkshire were highlighting, a significant number of people within the armed forces community struggle with coming forward to say they actually need help. And that is something which is, again, similar in the general population of carers, but there are specific differences. And so it could be the units people served in, they have a very specific culture about not seeking help and about just getting on with it. Officers, we found out, sometimes find it difficult to come forward. if the couple have served together, so spouse and the serving person, if they're used to garrison life, military life together, then even the carer can find it difficult identifying, because always the prevailing culture is you get on with things, you handle things yourself. Other issues can be older veterans find it a lot more difficult talking about mental health issues than the younger ones. And also in some of the units, and it tended to be the elite ones, mental health is something they don't want in their records because it really does affect future employment opportunities, particularly as a lot of them would be looking to go into security, things like becoming bodyguards and stuff like that. And it's really important that we actually understand the significant number of people coming out of our armed forces who are already being cared for. The military estimate themselves that 1 in 11 serving personnel coming out of our armed forces since year 2000 will be cared for at that point. And then just finishing off, another key barrier to engagement is just a lack of awareness amongst charities like Prama, statutory people, etc., of the specific needs around the armed forces, and particularly issues around mental health. So the focus tends to be on the person with the mental health issues themselves, and actually what we've discovered through our work is a significant number of the carers caring for people with mental health needs are developing significant mental health issues themselves. Just briefly, I think the things which have really helped us is that we've developed a really good network down here in Dorset, and a lot of the need we've actually identified, apart from the mental health need, is we think actually we can tackle. Next slide, please, Steve. So in terms of developing our work, what we're going to do is Prama is concentrating on writing a funding bid to the Armed Forces Covenant Fund, and that has to be in by August. And our colleagues in the Defence Medical Welfare Service are focusing on 2 Dorset-based charitable trusts. And just briefly, we're in a privileged position as charities. We do have other sources of funding we can pursue, which we want to, and we've divided up those targets because the Covenant Fund already fund the Defence Medical Welfare Service to do work elsewhere in the UK, whereas the 2 Dorset-based charitable trusts already fund Prama to do work. So we're approaching them differently because we've got a much better chance of success. Next slide, please, Steve. And basically what we want to do is each funding bid, the basis of it will be to enable more carers to become directly involved in the development and the leadership of the support services we want to build on. And what we specifically want to do is more work with supporting carers with their income and accessing respite care. And that's particularly because of the younger age they tend to start caring at. There's a lot of issues around income, welfare benefits, and there's complications with military pensions and the national welfare programme. Obviously, from what I was saying earlier, we want to do more work around raising needs about the needs of carers, statutory and charitable colleagues, etc. And as Berkshire highlighted, we want to do a lot more work about developing peer group support, because that was a key part of the feedback. And then lastly, and this won't be an immediate project, we want to start working with our colleagues in the mental health services to really look about how we can support carers of people with mental health needs. Next slide, please, Steve. And we've just got to continue learning because we recognise there's an awful lot of young carers involved in the armed forces community. We need to get back to them. There's specific geographical areas where we need to do more work. And likewise, we need to do more work about just integrating what we're doing. So, for example, mentioning welfare benefit stuff, we should be sharing our knowledge with local other providers like the Citizens Advice Bureau. And just finally, as Berkshire said, we've got to just continue sharing our learning regionally and nationally. It was interesting, I think someone's put up in the chat box whether we could have a specific module on armed forces carers, and I think that's something which we could achieve with our partners, that we could draw up a module about the key issues we've learned. And then just lastly, the Ministry of Defence has a strategy for families for the armed forces, but interestingly, there's very little mention of carers in them. So one of the things we need to get on with is to write to the Ministry of Defence to say, can you look at this again? And particularly to look at the Canadian model, where everybody leaving the Canadian military, not only does the personnel who are leaving get assessed, but their spouse stroke immediate family member gets assessed as well. And what they're finding out in Canada is up to 1 in 5 leaving, every 1 in 5 people leaving their military are already being cared for. And it's much better setting up support then than waiting until problems escalate in civilian life. Thank you.
Thank you so much, Chris. It's been a really eye-opening piece of work with some great plans for the future. So in the interest of time, handing straight over to the team in Cheshire and Merseyside. Thank you.
Good afternoon, everybody. It's Kate Ormrod. I'm the Operations Manager at Cheshire and Warrington Carers Trust. Our project, Courage to Care, is in partnership with Cheshire West and Chester Council and NHS Cheshire Clinical Commissioning Group. Next slide, please. I'll move on from that one as well. I'll try and cut it down a little bit. So why Armed Forces veterans? We wanted more understanding, and there's a need there in this under-supported group. Next slide, please. So our 4 main aims were high quality engagement, to co-produce a set of recommendations for best practice. We wanted to map our networks in our area and demonstrate the potential for further improvements. Next slide, please. So what did we do? We sent surveys out, we asked our networks, we joined groups, we had some one-to-one interviews. What it's really important to note that we were starting completely from scratch. So we're a carer service. We had no links with armed forces or veterans. It really was a from scratch project. So we just reached out as far and wide as we can with other voluntary sector groups, our partners, to get as much engagement as we could. Next slide, please. So part of the project was to map all our services, and on the left hand side it's all the local services that and connections to armed forces. On the right hand side the more national networks. So every person we spoke to gave us more information, and we're able to get a really detailed view of our local and national picture with supporting veterans. Next slide, please. So we did have some COVID challenges that other groups have mentioned. Locally, there's been so many surveys. I think people waited and waited and waited, and then everything came out at once. Care has been shielding and cautious. There's been reduced opportunities for engagement. Care has been selective in what they come into and what they're not coming to and what they're engaging with. And of course, the networking with our partners has gone remote. There's less the marketplace events, and we're really missing that kind of networking that was out in person networking. Agencies have been gatekeeping service users, protecting them in a good way, for good reasons, but we've found that sometimes it's been harder getting through and speaking to groups. And the use of technology. 23.4% of our registered carers do not have an email. So we've really found that reaching the carers via computerized means isn't cross board for us. Next slide, please. So partnerships have been key. So our local partnerships, the MindCap partnership, gaining all the information and really drawing out what's happening locally and what's happening nationally. It's been fantastic to have the Mind the Gap veterans group. We have spoken to each other, some fantastic learning from each other. So it really has been the fruition of our networks and partners. Next slide, please. So key project learning. We've really got that carers want the different formats. There are carers that want to see electronic information electronically, Facebook groups, particularly in serving armed forces. And then the veterans mentioned, we want it in community buildings. We don't want it electronically. We want information out there, posters. So it really came through that a variety was needed. Language, like all the groups in this session, language has been really key. Some of the things that we've that's been shared with us is assistance and not benefits because of the stigma, and that not liking the term carer because it's a family member, and we've heard that before today already. And relationships being key. And about a relationship, not one-off contacts. The armed forces veterans and serving armed forces really wanted to know the person that they're dealing with and that they're supporting them, and it was really important, that relationship part of it. Then about promises, and we've heard before today about a lack of trust, and that came through as well, that promises don't live up to reality. Do what you say you're going to do, which is so key to support, as we know. And then utilising the networks that are there, because they're there. And by using those networks, services like ours can really get in there and make a powerful change for carers. And what came through as well is making the support easier for people to access. There was really a sense of that everything was out there, but it can be overwhelming for people, and sometimes the last thing they want to do at the end of the day is to go on a website. Sometimes they just want to have somebody there already, knowing where this person is going to be, so that they can tap into the support. And individualised support, recognising that everybody's different. Next slide, please.
Just to let you know, Kate, it's 12:36, so I'm going to just ask Steve quickly if anything's going to start automatically happening. Hate to interrupt you.
No, that's fine. I'm the one
okay.
which this thing, so it's all right.
Steve's got the power. All right, thank you.
Okay, I'll go as briefly as I can. So beyond Courage to Care, we've pledged to the Armed Forces Covenant. We are adding the Armed Forces training modules into our internal training matrix. We've incorporated the Armed Forces in a case recording data set. We're utilising that mapping exercise so that all of the support and staff practitioners are able to access it and support people that come through the service. We've got to build on the partnerships that we've made, that, you know, not let them fall but by the wayside. We're really going to utilise those partnerships and build on our success. And then maintain the strong links with Dale Barracks. They contacted us today actually to invite us to an event, which is fantastic, on the 28th of June. So we'll of course do what we will make sure we're there. So it's about maintaining those links with the barracks, which I'm really pleased about, and incorporating this learning into our service delivery. And then finally, to secure additional funding for an outreach programme, because there's so much more to do. Like I said, we started from scratch and there is so much more scope for this, hence the project and the scoping project. So the last slide very briefly. Next slide. So what we want to do is to develop a Courage to Care outreach programme to inform dedicated workers, build on networks, identify relationship-based engagement for earlier identification, which was mentioned earlier, encouragement, longer-term outreach, pop-up sessions, building that trust, and the support, which is person-centred, individualised and ethical, to strengthen those relationships, because there has been a feeling of them and us, and actually the bridge needs to be gapped, and we want to be part of bridging that gap. Thank you. And then finally, there's contact details on the last side.
Thank you, Kate, so much. Absolutely fantastic work. And as I say, I'm sorry we've had to rush you through, but we'll be sending out Q&A afterwards. Please, if anyone wants to know more about Kate's or any of the projects, do let us know. We can connect you, and we'll be sending that Q&A document out if there's anything anyone wants us to address. I'm going to stop talking and turn to Steve, who I imagine wants to pop us back into the main room now. But thank you so much to everyone.
Everybody, I'll just see if I can transfer yours. 2 seconds. Are you back with us, Neil?
Yes. Hello, everyone. So we didn't get moved when everyone else got moved. There was just a few of us left. So good to be back here, and some fascinating presentations, and again a great deal of learning, which is relevant for all of us really working with unpaid carers and different parts of our communities. So I hope you enjoyed those conversations, and thank you very much for everybody who shared your work and answered questions. And just a reminder that those case studies are available on the NHS Futures platform to if you want to go and look at them in greater detail. So thanks very much for joining us again, and we're going to move now to think about the external evaluation, and really pleased to welcome again Sarah to join us from Liverpool John Moore University.
Thank you. Thanks very much. Thanks very much for having us today. It's been great to hear again about all the amazing work all the projects have been doing. I know there was lots of interesting ideas and discussion in the breakout room I was in, and I'm sure that was the case in the others as well. So thanks again for having us. So my name's Sarah Greenhow, and I'm here with my colleague Sarah Tickle. So we're kind of going to do half and half of the presentation. So I'll pass over to Sarah about halfway through this. So you'll hear from both of us. So just in case you're not aware, we've been carrying out the external evaluation of Mind the Gap this year. And we also did this last year as well. And as has been introduced, we're from Liverpool John Moores University. So today, we're just going to provide a brief overview of some of the common learning points from our evaluation, and we've got lots more detail in our final report that will be shared with you. So next slide, please. Thank you. So just before we start with our external evaluation, we just wanted to highlight the reach of Mind the Gap 2021-22. So what we've also done in addition is have a look at everyone's final reports, and we've just put together a table there on the slide just to show how many carers have actually been engaged with this year. I think this just highlights the really amazing reach of Mind the Gap this year. So you can see that 448 carers have been engaged with across the embedding and scoping projects this year, and within that 180 have been newly identified and 76 are now accessing support as a direct result of Mind the Gap. So it just really highlights the impact of the projects, and there was also really clear plans to spread that learning and support even further moving forward. And this was in everyone's final reports, but we've also picked up on this in our evaluation as well. And we've identified some common learning points across this vast work from this year. But we also recognise that there are nuanced and specific needs of each community as well, and we'll pick up on some of that today. But more detail about that is in our report as well. Next slide, please. Thank you. So just a little bit about the work that we've been doing over the last few months. We have focused our evaluation on 10 projects. You can see them listed there. In relation to the communities we focused on. So we evaluated all 4 embedding projects, which focused on young adult carers, the LGBTQ+ community, Gypsy, Roma and Traveller community, and also learning disabilities and/or autism. We were also asked to explore and evaluate 6 scoping projects that focus on 2 key themes around armed forces and veterans and drug and alcohol dependence, to explore these areas in more detail, as it was felt there was a lack of evidence around those 2 communities. So we've used qualitative methods of engagement, and we've spoken to and engaged with 28 carers and also 78 wider beneficiaries, including project members and also partner representatives from different organisations as well, to think about the sustainability of the learning moving forward. So we've done this in a variety of ways, including interviews, focus groups, and we've also observed different multi-agency meetings as well. So what we'll do now is we'll just outline some of our key findings related to our research questions around carer experiences of Mind the Gap, the challenges they face as carers, their hopes for the future, and also thinking about that sustainability as well. So next slide, please. Thank you. So firstly, we explored how carers experience Mind the Gap and their experience of the project. And this was overwhelmingly positive. So it was clear across the 10 sites that we evaluated that the scoping and embedding work conducted by all the projects was successful in terms of being a positive and rewarding experience for all the carers that we spoke to. And they felt listened to through the scoping engagement work, and also those who took part in the embedding projects felt supported through the intervention that they'd experienced. And the participation had allowed carers to raise issues and concerns that were personal to them. And for others, it had also led to them feeling connected with other carers and to access support as well. Carers really valued being part of the process of developing recommendations and that co-production of outputs. So they felt valued and part of service development. There were also some specific aspects of participation for each community that were important to them, which is explored more in our report. But a couple of examples are that the protection of anonymity that was carried out in the projects related to drug and alcohol dependence that we looked at was really valued by carers, and that protection of that anonymity. And also another example is in the Gypsy Roma Traveller community, the support of trusted link workers to help them to participate was also valued. So it was just important to recognise that there are specific needs to help enable participation. So next slide, please. So you can see here some carer voices. So throughout our report, we've got lots of different quotes highlighting carer voices, which has been really central to our approach. And you can see there are a few different examples that you can read. But just to highlight one of those quotes, the second one there was, "I felt it was the first time that anybody has actually listened to my opinions because I've been fighting for years." And I think that really highlights the impact of that participation in the Mind the Gap project and that feeling of being listened to and those opinions taken on board. Okay, next slide, please. Thank you. We also explored the challenges faced as carers to identify, the barriers that carers face, and also to think about whether Mind the Gap was addressing some of those issues and recognising those. So we wanted to understand the challenges and barriers that carers face in order to address those within service delivery. So firstly, we have considered there are some common challenges that were being raised across different projects. And some of these were coming up in the breakout room that I've just been in as well. The first one being the kind of not identifying as a carer as being a barrier to access and support. There was also carers raised a lack of understanding and awareness of the specific needs across services such as health and education. There was also barriers relating to caring for complex needs of their loved one, and the impact that this had on their own health and well-being, such as loneliness and the impact on their relationship and family. And another common challenge was some barriers to accessing healthcare that carers were facing, and this included a lack of inclusion of the carer in the healthcare of their loved one. We also highlighted a range of challenges that was quite specific to different communities, or were highlighted as particularly important for them. And we've got a kind of a range of these within the case studies in our report, but some examples are on the slide there that were linked to particular communities or raised as being particularly important, such as a lack of adjustment in education for young adult carers, a reluctance to accept help within the armed forces community, blame, shame and stigma around drug and alcohol dependence, and literacy barriers for the Gypsy, Roma and traveller community. What we did find though is that it was noted by some carers that the embedding interventions had helped to overcome some of these challenges. So this included interventions such as the transitions passport for young adult carers, the promoting digital confidence film for carers of adults with learning disabilities and or autism, the LGBTQ+ carer support group and professional awareness training, and the bursaries and practical support that was being provided for the Gypsy, Roma and traveller community. So it really highlighted the impact that those embedding projects were having this year, and the importance of continuing to embed that learning from the Scope Insight projects this year, which is obviously great that opportunity is available next year as well. So next slide, please. Thank you. So again, just some carer voices to highlight those challenges, and you can see some specific issues that are raised within those quotes, but this kind of the one in the top right corner there, just that lack of understanding from people in the NHS and the wider public, and we come back to thinking about that later on, thinking about raising awareness and understanding moving forward. So I'll now pass over to Sarah.
Oh, thank you so much. Could we move on to the next slide, please, Steve? Thank you. So great. So I'll talk about the rest of our evaluation for the remaining slides. And as Sarah's already highlighted and talked about, it was really clear that through our evaluation that the embedding projects had already had a positive impact, particularly which was important for carers. And this was through the development of support and also through the tangible outcomes from those embedding projects. So in each of the embedding projects, carers spoke really positively, about the impact of the embedding intervention in terms of the impact that had on their lives, and how they would also recommend that for other carers in the same position as themselves. So there had already, therefore, been an impact on the health and well-being on the lives of those carers in those embedding projects. And that was through supporting transitions for young people. In terms of young adult carers, as Noah excellently talked about this morning at the beginning of the presentation, in terms of the difference this made. There was also impact there through improving digital participation for carers of adults with learning disabilities and or autism. There was also impact through improving peer support for carers in the LGBTQ+ community, and also through providing practical and financial support in lots of different accessible ways through link workers for carers in the Gypsy, Roma and Traveller community. As you can see on the screen there, in relation to the scoping projects, they were required to understand what would ensure more carers from vulnerable communities to access support so that they can maintain and improve their own health and well-being. And the carers that participated in our external evaluation in terms of the scoping projects had a range of hopes and recommendations for the future. So these included, for example, that they wanted more support for carers relating to a range of specific needs, including digital inclusion, having a central point of information, and also in terms of peer support. Carers also wanted a joint and or family approach for carer and cared for to promote carer inclusion in the care of loved ones. There was also hopes for the future in terms of raising awareness, as Sarah's already talked about, in really understanding the role of a carer for that specific community. There was also recommendations for hopes for the future in terms of individualised support due to complex and specific needs, and also in terms of the importance of reviewing terminology in relation to challenges when people do not identify as a carer, which related to all of the sites that we evaluated. So all the outcomes that carers wanted to see as a result of the Mind the Gap projects discussed with us in our external evaluation were represented in the findings and also in the recommendations in the reports produced by each site. So therefore it was clear that the Mind the Gap projects conducted by each site did indeed measure what mattered most to carers that we spoke to, and also about the next stage being for implementation and also achievement of these. So real change and improvement to carers' overall well-being can only be achieved by putting into practice the recommendations from each of those project sites. And those tangible outcomes need to stem from this scoping exercise for carers to see the impact of their contributions and also, to see those in those future plans. So whilst all carers did hope and hoped for change and shared some of the common goals, it's also important to note that carers from each project had specific tangible outcomes reflecting the need of that particular cohort of carers from that community, which are all discussed in each of the individual case studies in our final report. Next slide, please, Steve. Thank you. So as you can see on the screen there, we've included a couple of quotations from the carers that we spoke to in the external evaluation. And you can see across all sites, carers had a range of hopes for the future, particularly around raising awareness about what it means to be a carer, and also in terms of services being made more easier for carers to be accessible. They also talked about wanting to see improvements in the future, particularly around the term carer, as we've all witnessed and talked about today in the presentations. And you can see from the quote there in pink, number 9, one of the carers said that there's a need to rebrand from veteran, as younger ones don't identify with this term, and also rebrand the term carer to looked after or helper, and a need to educate carers that they are a carer. So particularly, one of those common learning themes across all sites was about not identifying as a carer, but there's also learning there, around also thinking about the word veteran, and particularly when we're focusing on the armed forces community. So can I have the next slide, please, Steve? Thank you. So in our conversations and also in the observations of wider beneficiaries, which included project members and also partners across the sites, there were clear plans for sustainability, and embedding projects were continuing to ensure that the interventions implemented in phase 2 were sustainable, and also that the knowledge and learning from both phase 1 and 2 have influenced the service provision for their community. So the scoping projects had co-designed recommendations that had already begun to have an impact, and there were also plans to sustain and also implement these further moving forwards. So all of the 10 case studies that we evaluated were all committed to continuing with their project aims. And these were through, as you can see on the screen there, partnership working, also through changes in culture and practice. This was also through producing durable outputs and embedding those interventions, and also sustaining through removing barriers. So what we can see from the evaluation is, despite obviously the commitment to sustaining these projects, we also obviously acknowledge there were some challenges to sustaining the learning there. So sustainability therefore depended on a number of factors, which included continued funding, also around networking and partnership working, including buy-in from wider services, and also around raising awareness and understanding. So therefore,
Hello.
in order...
Sarah, sorry, could I just, we're running out of time, so if you could wind up, that would be really helpful.
Yeah, no
Thank
problem.
you.
Thank you. So if we move 2 screens on then. Sorry, Steve. So we just missed some of the quotes from the wider beneficiaries, but obviously you'll be able to see these when they're shared. So just to end really, in terms of talking about some of those common learning points, we just want to really highlight that in the external evaluation, we can really see that those Mind the Gap projects did measure what mattered most to carers. The embedding and the scoping work did have an impact on the lives of those carers that were involved within it. But we also need to remember that in the future, there's some common issues there to do with language and terminology, about raising awareness and understanding about the role of a carer, and also particularly thinking about that joint family approach. So we can see that obviously that there are issues that have been continually raised throughout the projects, and also we have those common learning points that can be applied across all sites. So next slide, and then I will finish, I promise. So what we would like to end with is to say that we have now sent over our final evaluation report with NHS England and Improvement, which will be shared in due course. Sarah and I are currently working with designers to produce a shorter, more accessible format of the report, and also an infographic. So as soon as these are ready and available over the next couple of weeks, we'll be able to share those with you as well. And as I say, everything we talked about today is in that final report, which you'll be able to have a look at. So that's the end of our evaluation. So thank you ever so much for that. Thank you.
Put my mic back on. Brilliant. Thank you very much. As you say, that there's a lot in common that is relevant for all of us there. So and we look forward to seeing that final report. So can I hand over now, Jen, for the final word?
Quite exciting getting the final word. Could I move on, Steve? So go to the next one as well, Steve. So the person who's been waiting very patiently by my side has also become the focus of my mantra around carers work, and I think very much reflected from the 2 Sarahs around the evaluation, that there has been some fantastic movement forward, and it does feel like there's a bit of a sea change in how things are moving with unpaid carers, but we certainly can't take our foot off the pedal. And I think the reflections around the use of trusted link workers, thinking about language, that conversion from identification to actually accessing services through embedding projects is a really powerful story, and absolutely reinforces the fact that we have to do far more in terms of co-production, getting out and working directly with people within our local communities, and really being more PAD. So thinking about how we can be really purposeful in this work, looking at how we can really improve accessibility. And I think the enthusiasm for easy reads across everyone is a real sign that actually all of us like to have a really accessible route into stuff. It does take determination. We've had questions before about why we can't put thousands and thousands and thousands of pounds into this. And we actually just have to reflect where health, social care and other parts of our partnerships and stakeholders are, in that we live in a very tight economy, and what we want to do is to make things to be really sustainable. And so that really fits in with that determination. We want things to go beyond the life of a project. And as part of that, we need to be systematic. So great to see how ICS, ICB boards are getting involved and starting to really embed this work. So my final word is really, let's all be more pads, who you'd think has been really good, but actually was just woofing at me until I gave him a dental chew. So he was being persistent as well, but he got his way. So thank you so much, everyone. We really, really appreciate all of the phenomenal work that's done. I think the evaluation shows just how powerful this is, and I look forward to seeing next year's projects as well. Thank you.
Brilliant. Thank you very much, Jen, and thank you everyone for coming. And I do hope that when you look at the system plans for the next period, there will be real opportunities for taking this work forward as part of those. So thanks very much, everybody, for sharing your work and for sharing your learning. It's great to be part of this community. Thank you very much. Enjoy the rest of your day.